Welcome to the pit crew model for cardiac arrest resuscitation. This course has three basic objectives. When we're done, you should understand the science behind high-performance CPR and know why we're doing it. Secondly, we'll cover how to do premium quality CPR with minimal interruptions and the proper rate, depth, and recoil for maximum blood flow. Last but not least, we will discuss the pit crew approach to cardiac arrest resuscitation and learn how to apply it. Pit crew resuscitation makes your response much more efficient, and we think you'll love the approach. Getting pulses back is a good start, but it's not enough. Our true goal as rescuers is to see that the patient is discharged from the hospital and returns home to be a productive member of society. What do we know that actually affects outcomes in cardiac arrest? Well, CPR is clearly the most important. It should be fast, but not too fast, adequately deep, and with full recoil. Early defibrillation clearly has a positive effect on survival. And therapeutic hypothermia is the only other treatment that's been shown to improve outcomes. There's some discussion of beginning this therapeutic hypothermia in the field, but there's no definitive information or protocol for that yet. There's one simple strategy for high-performance CPR. Do it right away and don't stop unless you're going to shock somebody. And how does that look in practice? 1, immediately starting compressions as soon as you've recognized the patient is in cardiac arrest. Continue those compressions without interruption. Even small pauses make a difference. Don't stop for anything other than a shock. When you do have to stop and shock the patient, keep your pause preferably less than 3 seconds. And that's a pretty tight pause, so we'll definitely want to keep it down under 10 around the shock, which is what we affectionately call the peri-shock pause. And we want to keep that down to as quick as we possibly can make it. And the fourth one is not to hyperventilate your patient. The more that we do positive pressure ventilation, the higher the overall pressure inside the chest is, and the less benefit we get from recoil during compressions. Recoil allows us to bring blood flow back to the heart, and that is interrupted with positive pressure ventilation. So we are going to reduce significantly the number of ventilations per minute. You might be surprised. Chest compressions require good body mechanics, just like any other physical task we do. To do it properly, you have to snuggle up to your patient with your knees touching the patient's arm or chest. Lock your elbows and lean over the patient so your shoulders are directly over the patient's sternum. Each compression should be at least 2 inches deep. That depth pushes the most blood possible out of the heart and the surrounding tissues and moves it through the arterial system. Just as important is the recoil between compressions. The heel of your hand should actually come off the chest between each compression, allowing the chest to return to full size and drawing as much blood as possible back into the thoracic cavity and essentially back into the heart. The rate of compressions is just as important as depth and recoil. This chart shows the probability of surviving to hospital discharge based on chest compression rate. The best outcomes happen at a rate of between 110 to 120 compressions per minute. Notice how quickly outcomes get worse if you compress the chest too fast. Now, we've been preaching for a while to push hard, push fast, but there is such a thing as pushing too fast. So, keep your compressions at least 100 per minute. Shoot ideally for the window of 110 to 120 per minute. For chest compressions, we want you to keep going, don't stop. So you're going to have a regular cycle. You're going to check a rhythm, shock if indicated, and do 2 minutes of CPR. Check a rhythm, shock if indicated, do 2 minutes of CPR. That 2-minute CPR cycle is going to time your entire code. So as you progress, you'll make decisions on when to push medications, and you'll make decisions even around ventilation based on your 2 minutes of CPR cycle. Here's why we don't want to interrupt CPR, and we're not even going to interrupt CPR for ventilations, and I'll show you why. Look at the pressures created during CPR on this tracing. The pressures in the aorta are shown in purple, and pressures in the right atrium are shown in yellow. The aortic pressure is important for getting blood to body organs and tissues, including the brain. The difference between the two pressures is important in coronary artery blood flow. It's basically the care and feeding of the heart muscle during CPR, and those two pressures need to be different. See how the aortic pressure drops drastically each time compressions are stopped? It takes about 15 to 17 compressions to get the pressures back to where we want them to be. This chart illustrates what happens when CPR is interrupted every 30 compressions to give 2 breaths, which is why we're not going to do that. But more importantly, it shows what happens during any interruption in CPR and shows how important it is to keep those interruptions to a minimum, and when we do pause, to keep the pause time to a minimum. So let's look at when we actually have to interrupt CPR. The odds for a successful resuscitation are drastically increased if the pause before and after the shock, what we call the perishock pause, is kept to a minimum. If the shock occurs within 3 seconds of stopping CPR, the odds increase by a factor of more than 6. If CPR is resumed within 6 seconds of the shock, the odds increase by more than a factor of 10. And if rescuers can keep the entire pause under 9 seconds, the patient's chances of survival are 13 times better. Now, it's important that you realize it doesn't matter what the monitor shows after the shock. Immediately resume CPR. Even if you have an organized rhythm, don't stop to check a pulse here. If we believe we get pulses back at some point, we'll stop later, but we want to continue to do at least 2 more minutes of CPR before we stop to do a pulse check. When we arrive on scene with a defibrillator in our hands, whether it's a manual defibrillator or an AED, we have a tendency to want to put the machine on the patient first and then make a decision about whether or not to start CPR. The problem with that is illustrated by this chart. If we arrived within 1 minute of the patient going into VFib, then we have a pretty good chance of shocking the patient back into an organized rhythm and back into pulses. Notice in the first panel on this chart that initial VFib at 1 minute is very, very coarse. Now, these were induced ventricular fibrillation in pigs in a laboratory setting. So they induced VFib and took a strip at 1 minute, and you can see on this chart that that VFib is coarse and ready to go. Allowing the pig to go for 10 minutes without any intervention, run another strip, and you see that the VFib at this point is much more fine, much less likely to be successfully shocked. At the end, they did 3 more minutes of compressions on that pig that they let them sit there for 10 minutes. Now they've done 3 minutes of CPR and ran another strip, and you see how the VFib at that point now has become more coarse and much more likely to be successfully shocked. So it's important once we arrive on scene to get started on chest compressions first while we're applying the machine. So it goes back to this original goals and the original strategies. Start CPR immediately. The only time we're going to pause is to shock the patient. Since AEDs can't think as quickly as paramedics, the process for defibrillating with an AED is going to be different than with a manual defib. When using an AED, one rescuer applies the patches while another is doing chest compressions. And once the AED is applied, find a femoral pulse. The femoral pulse should be palpable while chest compressions are being performed, and finding it does 2 things. Once the femoral pulse has been located, there's no need to find it during the analyze process, and while you're feeling it during chest compressions, you'll have an indicator of whether or not chest compressions are effective. At the end of the 2-minute CPR cycle, go ahead and stop compressions and analyze. Whoever's doing CPR should keep their hands hovering over the patient so you can clear, be away from the patient's chest so the machine can analyze appropriately, but have your hands hovering over the patient's chest ready to start compressions as soon as the machine begins to speak again. Now the machine will tell you whether or not it's going to shock. And regardless what it says, as soon as it starts to say shock advised or no shock advised, immediately resume compressions. If the machine decides to shock, it'll begin to charge. Finish 30 compressions before delivering the shock. Now when you're done with your 30 compressions, the machine's beeping at you. Everyone can clear the patient. Keep your hands hovering above the patient's chest. Everyone clears. You hit the shock button and you immediately get back on CPR after the shock. Don't wait for the AED to tell you. Using a manual defibrillator is different than using an AED. First of all, never use a manual defibrillator in AED mode. The benefit of a manual defibrillator is that we get to cut down significantly on the CPR pauses because we can identify the rhythm faster than the machine can. If you put the machine in AED mode, you lose any benefit of having a manual defibrillator at the scene. Also, when running a code on a LifePak monitor device, put the LifePak in the paddles lead and look at the rhythm through the defib patches. That allows us later, as the machine is recording that defib patch lead, it allows us to download the information, and using the impedance in the chest, we can see how often CPR was performed. We can then bring that feedback back to the crew, so you'll get an idea of how well you did and how long your pauses were during your code. Using a manual defib is all about taking advantage of the fact that you're in control of the machine. So as you come up on your 2-minute cycle of CPR and you're coming up on your next rhythm analysis, go ahead in the last 30 seconds or so, charge the defibrillator. Now charging the defibrillator during compressions, pre-charging we call it, gives us the opportunity to have it ready to go. So as soon as we recognize a shockable rhythm, we can hit it and move on during the analyze portion. Now remember, it's going to be beeping at you, so you don't want to have it beeping at you too long, so keep it in that last 30 seconds or so. The other important note here is LifePak 12s and LifePak 15s will hold the charge for only 1 minute. So if you charge it too early, you may actually lose your charge at about the time when you wanted to hit the button. Now during the compressions, so after you've charged your monitor, go ahead and find femoral pulse. Just like we mentioned before, we highly recommend that you wear gloves. Find that femoral pulse and you will then be able to recognize A, how good your chest compressions are, and B, you'll know where the femoral pulse is so that when you stop to analyze the rhythm, if you have an organized rhythm, you'll immediately know if you have a pulse with it or not. Now rescuer 3 is the rescuer at the head of the patient, and we haven't discussed roles yet. However, rescuer 3 is in charge of multiple things, the two most important being the airway and the timing of the code. So rescuer 3 is going to tell us when we're getting close to our 2 minutes, and rescuer 3 is going to tell us when we've hit 2 minutes, and it's going to go ahead and clear the patient. Rescuer 3 clears the patient, and we want to analyze our rhythms within 3 seconds. So very quickly here, we're going to show you 3 rhythms, and I want you, and I don't have any way to check this, but I want you to identify as quickly as you can which one you're going to shock. Now the difference between an AED and a paramedic looking at these rhythms is that the paramedic probably almost instantaneously recognize ventricular fibrillation. So at that point, the paramedic would hit the shock button and the whole team would be back on chest compressions. Remember, when we clear the patient, we want to keep our hands hovering over the patient's chest, so as soon as we shock, we're right back on the chest. Even if you see an organized rhythm after the shock, we're going to continue CPR. We're not going to stop and check a pulse. Ventilation during pit crew resuscitation in Stanislaus County will only receive ventilations if there are at least 3 rescuers at the scene. In situations where there are only 2 rescuers, we will place an oropharyngeal airway and administer O2 by non-rebreather mask. Once we have at least 3 rescuers available, we will ventilate the patient twice per minute or once every 30 seconds. Use a two-person BLS airway. The rescuer at the head will hold the mask in place with two hands while another rescuer squeezes the bag. Only squeeze the bag with one hand and try to keep the volume of air down to about 300 milliliters. Place capnography on the BVM. This is a little different than we've seen in the past. We typically only use capnography with endotracheal tubes, but this will allow us to monitor the patient's end-tidal CO2 levels during the code, even with a BLS airway. However, it's extremely important, as long as you're holding the mask on the patient's face, to maintain that seal, or capnography will not be accurate. CPR is not effective during transport, so patients should not be transported until you have return of spontaneous circulation, or ROSC. It's understood that not every patient will survive cardiac arrest, but VFib should survive. Continue to work on VFib patients until they are no longer in ventricular fibrillation, plus about 10 minutes. Ideally, when they're no longer in VFib, they'll have pulses. Ventricular tachycardia patients should be considered viable until they aren't in VTAC any longer as well. For other rhythms, survivability is not as clear. In those cases, don't consider stopping resuscitation before attempting for at least 20 minutes. Staying on scene for 20 minutes plus is only recommended for patients that are of what we presume is cardiac etiology. For patients of a trauma etiology or kids or any of the other typical